Hello.
Good evening, I'm hearing you.
Okay, maybe there's something wrong with his network. But sir, you're highly welcome. We want to appreciate the kind gesture, and I hope that everybody will gain maximally from this session. I would like to recognize some of our very, very senior colleagues. Some of our teachers are also here with us. Thank you all for joining in. Dr. Anya, I think we can start. It's already past 8 now. Sir, you can go ahead.
It's okay. Good evening, everybody. Dr. Nora, thank you very much for having me. And let's just say we'll see if we could scratch SICS and hopefully put ourselves in a better position to care for our patients. Please, if you are hearing me, confirm audio clear, video clear. Give me a type on the chat, audio clear, video clear, please. Let me know that I am not a robot. Please help me type audio clear, video clear. If audio is clear and video is clear. And if you're not a robot, type I am not a robot. Okay, thank you, everybody. If you're not a robot, type I am not a robot. Okay. Thank you for this. I think it was yesterday morning that we discussed SICS, and I told Bature that, look, SICS is not something you gloss over. So we had an understanding that we should have a week-long discourse about SICS. So it's okay by me, and I'll be glad to be of private assistance to anybody who wishes to have more videos and have more discussions. But for today, with your kind permission, I would like us to revisit what we did yesterday morning. It felt like we were rushing it, but please, let's revisit incision in manual SICS. Usually when I do 10 teachers, the first day is discussing video editing apps for cataract surgery, how to use video editing app. My best editing app is CapCut. Usually we discuss how to acquire videos from YouTube, other sources, how to edit videos so that it becomes surgically relevant in terms of training. Well, probably that will come up at the last day. It's a 7-day project. So let's look at what we did yesterday. Tomorrow we'll start on anesthesia in SICS. With your kind permission, I'd like to share my screen, please. Do I have permission, Nora, to go ahead? Share my screen?
Yes, sir. Very well, sir.
Great, thank you. So I share my screen. What do I share now? Let me share this. All right. I'm sharing my screen. Please confirm. Let me play the video so you can tell me if it is streaming effortlessly. Please confirm streaming while I reduce the volume. Is this streaming properly, please?
Yes, sir. We can see the cursor.
Is this streaming properly, please? Someone should guide me, please.
Yes, sir. It is.
Okay, I think my audio has been reduced. I'm hearing somebody in the background faintly. Okay. All right. Okay, please. I have some charts here, and the chart says, can we take the pre-test? Oh, Mustafa, I'm so sorry, please. I'm so sorry, please. Yes, sir, you can go ahead, please, sir. Okay, I'll pause until Mustafa is done. All right, thank you. Mustafa, please, you can go
Okay,
ahead.
so you can continue. I will send the pretest to the chat box so that people can fill in the Google form.
Oh, great. Thank you, sir.
Yeah.
All right, so let us start. With your kind permission, I'll play this video and we'll keep picking it up as we go. So this surgery was done sometime last year, if I'm correct. Please forgive me if I can't remember exactly. So this is SICS. It has been edited with a slow motion of half of the speed. All right, so we said incision in SICS is a combination of 4 or 5 steps, all culminating to form incision in SICS. The first is conjunctival peritomy and reflection, while the second is scleral incision.
Yeah.
The third, yes, please. The third is scleral tunneling. The fourth is main access to the intracameral space. And the fifth are the accessory side ports. And one of my teachers used to give us a code. He said, whenever you're holding the knife, you are still doing incision. So that was the code he gave to us sometime. So incision in manual SICS is to expose the conjunctiva adequately and incise on the sclera, tunnel through the sclera, then have access, main access into the intracameral space and accessory side ports. So this is conjunctival peritomy and reflection. The first thing you always do when you are approaching SICS is to maintain the globe in a stable position. 2 millimeters before the limbus, you are going to find the tenon and the conjunctiva fused together before attachment at the limbus. Now, if that is constant across board, that means a bold grab of the conjunctiva tenon complex will give you an effortless incision. Advance the scissors underneath that. You will have both the conjunctiva and the tenon giving way. So what I do is I always grab to make sure I'm holding a combined conjunctiva and tenon. In that way, there's very minimal movement with scissors and knife. Now, let me explain what I've just done. Because I find myself doing more of trabeculectomy, and it's a system I use in trabeculectomy. So most of my conjunctival incision will start at 12 o'clock position. That is my personal preferences. But anybody that is right-handed or left-handed may choose to start at 10 o'clock position and or at the 2 o'clock position. But whichever position you want to start, the basic things are these. Maintain as much as possible the eyeball in primary position without wobbling. Please, so far so good, type for me TOG. On the chat box, type TOG. TOG are spelled T-O-R. Let me type my own because I'm also a student. So I type TOG. TOG. I type TOG. So please help me type TOG. If you're with me, give me some morals. Type TOG. And fast fingers, please Google what is TOG for me. Fast fingers, please Google what is TOG and put on the chat box. How do we overcome the wobbling of the globe? Let me show back what I did. All right, so let me start over here. We said TOG, wobbling of the globe. And how do you overcome the wobbling of the globe? In physics, there's what is called no work done. That also means you are advancing in energy, dissipating energy, but there's no effect to the energy one is dissipating. So in physics, it's called no work done. In eye surgery, you can have a sharp scissors. You can have a firm holding forceps and still no work done. So how do you overcome it? I want to show something I just did here. Okay. First of all, talk to overcome it. Please, this is on slow motion, please. All right. The first grab, and I pulled it up. Because of my type of anesthesia, posterior subtenon anesthesia, I have complete anesthesia, but minimal or some form of akinesia. So I do not have complete akinesia. Because I can rotate the eyeball to any direction I want, part of my overcoming torque, wobbling of the eyeball, is to grab a combined conjunctiva and tenon together, and I lift it up. In that manner, I have created some tension. So my scissors, even if my scissors is not as sharp as I want it to be, I will still be exerting energy and achieving something. This is one way of overcoming wobbling of the globe. Stabilize the eyeball, hold it firmly, and tug it up a little. All right, so let's go ahead. Undermine underneath. See your scissors. Go back and pick the tenon combined with the conjunctiva. Then exercise. Okay. I've mentioned one way of overcoming wobbling of the eyeball. Watch this part. Let me go back a little here. All right. So watch what happens here. All right. First of all, in this position, my position of action is very close to my position of support. So I will achieve an effortless conjunctival peritomy because the eye will not wobble. I'm holding on the combined conjunctiva and tenon together. I'm lifting it up a little to stabilize the globe. But most importantly, the position of action and the position of support are close together. If I lengthen the distance between position of support and position of action, the globe will still wobble on me. And according to the law of physics, no work done. That means you might end up spending 10 minutes just in conjunctival peritomy and reflection. So let's continue. So let me type on the chat box. Chat box, chat. Overcome wobbling by holding family action to support. I don't know what I typed, please. If it is grammatical error, forgive me. All right. So I'm cauterizing. There is a school of thought that says any form of cauterization will induce some form of scarification. I don't know if that is true. If it is true, to what extent is it true? I will agree in principle that any form of cauterization will introduce scarification. But if it is significantly important, I cannot tell. So if you need to cauterize, my cauterization is set at, by default, Oatly machine says at 60%, but I reduce mine to 40%. And if I'm doing trabeculectomy, I set my cauterization at 20%. Okay, so the first stage of incision in SICS, to the best of my knowledge, should have been completed here, which is conjunctival peritomy and conjunctival reflection. So let's go to the next step, which is scleral incision. Okay, the question is, how do you start scleral incision? Let me type on the chat box. Please type for me anchor points. Anchor points. Those are my words. Anchor points. Please, if you are there, give me thumbs up. Anchor points, give me thumbs up. Anchor points, give me some thumbs up. Let me know I'm not alone. All right, one person is with me. Two people. Three. All right. Anchor points. Anchor points. Let me explain anchor points. I'm typing at the chat box. Beginning and ending of the incisions. Am I correct? Yes, I am. Please forgive the typographical error. All right, so anchor points are the point at which you start your incision and at the point at which you finish your incision. So the beginning of the incision length from beginning to the end. It's a reason why anchor points are important. Number one, they create stability of that incision. That also means if your anchor points are intact and not avulsed, you may not need sutures. If the anchor points are intact throughout the surgery, that means you're less likely to induce secondary astigmatism in this incision. So the anchor point is the beginning and the end of the incision. Okay, let's look at this. I now made this incision a frown incision, starting from down, a curved C, inverted C, and that is the incision. The question is, how do you make a frown incision? I still have some arguments with my colleagues. Some believe straight incision is better for a beginner. I don't believe that. I have my reasons. Frown incision is the best. So why begin with a difficult incision? If frown incision is the best, then why begin with a difficult one? Why a frown incision? The whole essence of SICS is a scleral tunnel, delivering the nucleus through a tunnel. And when you have delivered the nucleus through a tunnel, the tunnel will oppose on itself. In that process, it's a closed unit. So if I am doing a scleral tunnel, a straight incision is very difficult to maneuver, even in an experienced hand. In the morning, we played Mohanta Pradi's video. We saw him giving warning. Avoid this anchor point. Avoid this anchor point because he did not make a very good frown incision. So the question is, how do you do a good frown incision? Let me stop here and we'll do this. How do you make a good frown incision? Okay. First of all, what I teach is this. Mark your 12 o'clock position, and by international convention, wherever the surgeon wants to start surgery, entry is determined as 12 o'clock position. That means if you change your position to the lateral side of the bed and you start at 3 o'clock, which is anatomical 3 o'clock, surgically becomes your 12 o'clock position. If I stay at the head of the bed, which is the anatomical 12 o'clock, surgically becomes the 12 o'clock. So when we say 12 o'clock position, it is surgeon determined. So the distance of your entry of your scleral incision, according to the book, should be 2 millimeters from the limbus at 12 o'clock position. So if one is making a straight incision, you can maintain that from the beginning of your scleral incision to the end of your scleral incision. But if you hope to achieve some frown incision, then I advise use a trypan blue in a cannula. Express it as until it gives a drop. Take a caliper, measure out 4 millimeters from 2 o'clock position, and use that trypan blue and make a dot on bare sclera 4 millimeters from the limbus. Go back to 12 o'clock position. Set your caliper at 2 millimeters from the limbus. Mark it out and use trypan blue to make a dot. Go to 10 o'clock position and use caliper set at 4 millimeters and take a mark. You can now use free hand to join 4 to 4. Please, if you're not a robot, I am not a robot. I'm going to type 4 to 4. Please send me chat 4 to 4. 4 space 2 space 4. So let me type 4 to 4. If you want a deep frown, you can map out 5 to 5. If you want the best, I've seen someone do 6 to 6. I've seen that before. I don't recommend that. I was also enjoying what he was doing, but my mind was not there. I like 4 to 4, some frown. 5 to 5 is a beautiful frown. I believe practice will make perfect. I believe that if you start using markers, some surgeons use vascular markings to judge for. Some will use the tip of instrument instead of using a die. But for someone who is just starting his or her career in cataract surgery, even if it is on your wet labs, use a trypan blue and make a mark. If you're seeing the mark and it's obvious, then join it. Even if you don't want to use knife to join freestyle or freehand, you can still use the trypan blue and join the 4 to the 2 and then the 2 to the 4. It might not give you an even frown initially, but with experience, with one surgery, with the second surgery, and the beauty of using animal eye to do your wet lab is this. One animal eye can give you 4 spaces for incision. So with one animal eye, you are sure of doing up to 4 times of scleral incision. So by the time you are finishing the second or the third, or at least the 5th animal eye, you must have done 4 times times 4, 5, that's about 20. I believe it's adequate enough for anybody to have some freestyle connection between 4 to 4 or 5 to 5. Why am I even taking time to discuss 4 to 4 and 5 to 5? Because by definition, it's called a scleral tunnel. The nucleus is big. The nucleus, equatorial diameter of the nucleus is ranging between 14 millimeters. 12 millimeters, 13 millimeters. In the bigger eyes, up to 14 millimeters. But imagine if you have a 6 millimeter incision length. That's already going to give you a problem in delivering that nucleus with equatorial diameter of 12 millimeters. But if you have adequate scleral tunnel, why the conjunctival incision is between 2 to 4 to 10 o'clock positions, the scleral tunnel expands towards 3 o'clock position and 9 o'clock position. is a scleral tunnel, and it will oppose by itself. Let me say this here. It's a discussion we had somewhere, and my position was clear. I'm glad some professors agreed with me. The success or failure of your surgery starts from the incision. If the incision is faulty, expect the rest of the surgery to become difficult. Ideally, if the incision is effortless, the rest of the surgery should, of a necessity, become effortless. So enough of talking. Let's finish up this. Let's see how we did 4 to 4 and how we tunneled. Mark 4 towards 2, freehand, back to somewhere 4. So this is the second stage of incision in SICS, which is first, conjunctival peritomy and reflection. Second, scleral incision, which you have seen here now. 4, please, if you could track my cursor, this is about 2 o'clock position. From here, the limbus down to the beginning of the incision, which is the anchor point, about 4 millimeters. 12 o'clock position, this is approximately 1.5 or 2. It was a freestyle, I didn't make any markings. Then from 10 o'clock position to where I finished my incision is about plus or minus 4. So I did 1.5, 4 millimeters incision. So it gave me some frown incision. Now look at it this way. The blade of the crescent knife, I think it's about 2 millimeters or more. Now, if you are tunneling underneath this sclera and it is 2 millimeters from the limbus, the chances of avulsion is terribly high. But if it is 4 millimeters away, the blade of the crescent can confidently be doing the tunneling without endangering the anchor point here. I need this point to be intact so that I will not be adding sutures. I need this point also to be intact so that I wouldn't have a hooding or a folding of this incision causing significant astigmatism. Now, I have a policy I usually adopt. Initially, I used to follow the Indians when they say 4 millimeter incision, 6 millimeter incisions, like we are winning a trophy. I ran into a trouble one time because the nucleus was more difficult than I had anticipated. So from there, to solve my problem after auditing myself, I was watching my video and I saw my mistakes. I decided to be making my incision length to be more than I will tunnel. So if I'm going to do 6 millimeter incision length effectively using it for surgery, I will make up to 8 millimeter incision length. Sometimes I will make it 10 millimeter incision length while I tunnel the one I want to use. The reason is simple. By the time the nucleus is difficult to come out from 6 millimeter tunnel, then you discover the eyeball is soft already. Expansion of that incision is difficult because you still have to tunnel the sclera. The key word is scleral tunneling because the nucleus is going to be delivered through the scleral tunnel. So if I had stopped at 6 millimeter long incision, I will only tunnel this much. And if I need expansion, the scleral tunnel will be difficult because the eyeball is soft. But if I make my incision length 8 millimeters and I tunnel a wider part of the sclera, by the time I now need expansion, it will become effortless. So if someone says, come and help me finish up this surgery, I will be worried in my heart if I can have a good expansion of the tunnel without endangering the rest of the surgery. So let's look at the third step in SICS, which is the scleral tunnel here. Okay. At this point, you cannot hold the anterior lip, so you use your crescent blade to create a dimple inside. All right. How deep should you go? Some people say the depth should be 1/3 of the sclera. Some say half depth of the sclera. Some say 2/3 depth of the sclera. Those who like calculations in physics will tell you 300 microns, some will say 400, some will say 500. All I know is I am not a physicist, and I don't know what to do as a surgeon. If this is my first surgery ever in life, I don't know how else to check for 1/3, 2/3, or half. But there's something every surgeon knows. When you pick it up and look, do you have sufficient scleral tissue above to avoid buttonholing? Do you also have scleral tissue beneath to avoid premature intracameral entry? So the bevel of the crescent will guide you to how deep you can engage the arterial lip. But most importantly, the surgical instinct of the surgeon is universal, and that is safety. The surgeon's instinct is safety. With that in mind, you can now check how far you can go. Let's go back to tunneling, please. Tunneling is important. Okay. Look at it this way. It goes in this way. It goes in. It goes in. It goes in. How far does it go? It goes in. All right. Just enough for me to hold. It goes in. It goes in. Now, at the 12 o'clock position, I discovered it has my incision was deep, so I stopped there. Chose a plane of action. The plane was safe enough. All right. I tried to do from beginning to the end because I won't have time to go back to this stage. Let's start all over again. It goes in again. Beginning of the scleral tunnel. Not every crescent blade will give you this bevel. So your safety instinct as a surgeon matters most. Have sufficient scleral tissue above to avoid buttonholing. Have sufficient scleral tissue beneath to avoid inadvertent early intracameral entry. So I'm looking at the tunneling here. All right. At this point, I'm trying to avoid multiple planar tunnel. Even if you find yourself doing multiple planar approach, is okay. When you are done, choose one that is safe enough. How safe should it be? Safe enough to protect you from buttonholing, safe enough to protect you from having inadvertent early entry into the intracameral space. Now, this is the concept of the 10 teachers. By doing 10 teachers, I can repeat this process minimum of 10 times, and I'll zoom on it. As I'm doing that, it sticks in my brain. So if this is a procedure I'm learning without anybody teaching me how to do it, I'll just zoom on the area of interest. I'm looking at, I don't know what people are looking, but I'm looking at the reflection of my blade, the tip of my blade. That's what I'm looking at. How do I know that my blade tip is still safe? I'm still seeing part of it. So I'm learning actually as I'm doing this revision. So this is the 10 teachers approach. Keep doing it. Somehow something will give. It will stick somewhere. Okay. My blade is obvious here now. I was scared, so I had to stop. Avoid making scleral incision twice. Even if you think it was superficial, you can use this approach to now deepen to a desired depth. So let's tunnel now inside. There is what is called a tunnel length. Incision length is separate. Tunnel length is another part. The textbook says tunnel to 1.5 millimeter into clear cornea. Some will say 1.5 to 2 millimeters into clear cornea. So if by default we have already done 2 millimeters from sclera to limbus, and we add another 1.5 millimeter into clear cornea, that means at 12 o'clock position, minimum we should have as tunnel length should be 3 millimeters, should be 3.5 millimeters. As you now widen towards 10 o'clock position and towards 9 o'clock and 2 o'clock position, it cannot be as long as it is because the tunneling is aimed at going back to 3 o'clock position, going back to 9 o'clock position as far as that can be. So it can accommodate any size of nucleus, no matter how big the equatorial diameter looks like. So let's do the tunneling and see again. I think after that, we'll make our accessory side port. Now, incision is not yet completed until you have done your rexes. I will discuss that when we're doing rexes, maybe tomorrow, honest. Choose a plane that is safe. This is where I disagree with Mahanta Pradeep. I think I've sent that message to him before. Mahanta Pradeep is highly experienced eye surgeon. When I asked him, I've seen his pictures when he was a resident. Mahanta Pradeep is practically more than 30 years in ophthalmology. So he can introduce his crescent blade maybe at 12 o'clock position and wiggle it into clear cornea. I tried it before and I found myself somewhere I never intended to be. I do not subscribe to wiggling. What is wiggling? Let me even say what is wiggling. Wiggling is put your blade and find it into clear cornea before you are now expanding. If you run into inadvertent early entry into the anterior chamber, the eyeball will soften on you. To choose a safer plane subsequently will be difficult. What do I do? Let me go back again to what I do. So I create 1 to 2 millimeter spacing and I watch. Is this safe enough? It's safe enough. Before I advance to clear cornea and I'm expanding. If I wiggle, I will just be stuck at a particular clock hour, and that is not always safe. Now, if you remember what we said about scleral tunnel, it should bury, if it is deep enough, the whole 2 millimeter or more of the crescent blade should be buried. Okay, look at it. It's all buried inside the tunnel. Yeah. It's buried inside the tunnel. So the crescent blade is buried inside the tunnel. And you tunnel the sclera, all of this, so that while you are walking between here and here, if there be any need for expansion, the sclera here is already tunneled. And because they will oppose by themselves, you don't need sutures. Now, let me make a bold statement. I hope I will not be in trouble after this bold statement. If you make a good incision before SICS, you don't have any business having iris prolapse. It's a bold statement, but I can defend myself. If you make a good scleral incision, you don't have any problem with iris prolapse. In fact, iris prolapse is an abnormality. Let's finish up and then we'll take questions. Okay. So far, I need an accessory side port. I've not created my main side port, so the incision is not yet completed. So this is the accessory side port. Now, creating accessory side port, because you've entered the intracameral space, aqueous will come out. That means the whole of the sharp tip of the knife should not go into the eyeball. It should just remain on the iris diaphragm so that one will not cause inadvertent capsular damage or tear of the iris. Please, thank you very much, Dr. Mustafa. With your kind permission, I would like to say thank you. Any questions and clarifications, we'll see if we can attend to them. God bless you all. Dr. Nurat?
Thank you so much.
Yeah, God bless you.
Thank you, sir. It's been a wonderful session. So do we have questions? Please, you can type in the chat box or you can signify if you have questions, please. You can raise a hand, then I'll ask you to unmute. So far, no questions in the chat box, and I've not seen any hand up. Okay. That means the lecture is well understood, sir. Okay.
Okay. Someone says,
So somebody's asked,
how do we hold the eye during incision with forceps? Oh, it's okay. I'm sorry, I forgot that part. Let me play the person and see if I got it. How do I hold without buttonholing? Because I'm sure my tooth forceps is scary. Yeah, I got to say, it's like vampire, and it comes and it grabs. So why am I not buttonholing that? I don't know, maybe from experience, but I think the way I conquered that buttonholing or avulsing the tissue was hold without causing yourself pain. So I use my hand. It's like holding the globe without dimpling the globe. With time, your hand will become steady. When you hold, suspend your hand as much as possible. If you're tired, there's a chance your hands will drop. And when it drops, you're not just holding, but you're crushing the tissues. Somehow, you might not be in the know at the moment, but with time, you start noticing this my grab is too firm and it's crushing the tissue. So you hold and hold gently. That's why I could use tooth forceps. Please, it is not part of the teaching. Standard teaching is you should use non-tooth forceps. Please, that is standard ophthalmic teaching. Use non-tooth forceps to hold and use sharp cutting scissors for cutting. When it is holding, don't crush the tissues. When it is cutting, cut sharply. That is standard ophthalmic teaching. But then you discover time will come, you might even use cutting board to support. So I think it's with experience. I don't know how much to explain it, but any forceps you give me. And then I don't know how many of us that have access to purchasing system in our hospitals. It's usually more what your nurses give to you that you use. So if they give you one that is appropriate as the teaching says, then we use. But if they give you what is not appropriate as the teaching says, I think we can just hold safely and gently without crushing the tissues, please. I think that's much I can say about that question for now. I have another question that says, what is the preferred instrument for making scleral incision? Some surgeons use blade fragments, surgical blades, and crescent and knife, etc. Or is it what the surgeon is comfortable with? Blade fragments, I don't think is anymore in the textbooks, please. We know it was sometime useful, but if you flip through most textbooks, you will not see blade fragments. At least I took time to look at I think last year's BSc series. You will not find blade fragments. Let's follow what the world is doing currently. Surgical backpacker blade size 15, okay, can be used if you have it. Crescent blade can be used. 15-degree side port can also be used as blade. The best is your surgical 15 degrees backpacker blade. But crescent is what I am used to. I have used side ports to also do my incision. So I think the standard should be our 15 degrees backpacker blade, but crescent blade knife is usually available. I still do not know how many teaching hospitals have the luxury of using one crescent per patient. Only very few. For me, I use 1 crescent per patient. So my crescents are still sharp when I'm doing my incisions, and also sharp when I'm doing my tunneling. And also I use crescent to expand after I've finished my rexes to deliver the nucleus. So blade fragment, please, or razor blade fragments, please remove it from your vocabulary before you mistakenly say it in public gathering. Surgical blade, yes, acceptable. Crescent knife, yes, acceptable. Then side pot can also be used. Can this recording be available? Yes, it can be available. Ask Mustafa Bature, he will make it available to everybody. Thank you, everybody. All right. Okay, another question is, let me see. What is the alternative for goat eye for wet labs? It depends on what's available in your environment. In the abattoir here where I live, I have access to goat eye. Goat eye is the smallest, so people think it is comparable to the human eye. I understand that. But if you have the normal eye is bigger. So if I'm learning trabeculectomy, I can do up to 6 maneuvers with 1 goat eye. I mean, so with 1 normal eye. But whichever is available in your environment. I have a recommendation, which I have told my residents. There is no way you can hinge all your surgical career and success in the hospital wet labs. Develop your own wet lab stroke dry lab in your own house. How? Get your tri-frame and put plus 275 or plus 25 or 2.00 or plus 3 into it and wear it because a magnifying glass. Ask your supporting fellow with you to give you illumination, or you can wear a loop if you do wish. And at least start suturing, start conjunctival peritomy and reflection, start practicing how to do scleral incisions in your house. So, for example, let's be theoretical here, and I pray 1 or 2 people can reproduce it practically by tomorrow evening. It's possible that you can do 100 practice of conjunctival peritomy, scleral incision, scleral tunneling, accessory, and the main entry port and accessory side ports. It's possible you can practice 100 of it before tomorrow evening. It's possible. So if you are waiting for the hospital wet lab system, there may be no light to even put the microscope. So I encourage, if it is possible, please, next OSN or you book for your own instruments. If you know you can't buy a full cataract at the same time, buy holding forceps, buy a sharp scissors. And if you ask, I can dash you one if you want. Thank you, everybody.
Thank you, sir. So there's a question. When using crescent blade, okay, the brand, okay. So one of our teachers, she's giving a suggestion.
Okay.
That we should be sure brand that we are using for crescent blades. Thank you, ma. Thank you so much, ma, for that.
Because some crescent blades, the Archon crescent blades are just totally flat. I don't know if anybody has noticed that. Some crescent blades have some bevel. With that bevel, you can now gauge how deep you want to go into the anterior lip of your scleral incision. But some crescent blades are terribly sharp, that one slice, you are actually into the vitreous. That is the reason why I believe the surgeon's instinct, which is worldwide, called safety, should apply. As a surgeon, when you make your first scleral incision, check the safety of what you've done. And if you know you've gone too deep, then come back superficial a little and tunnel it there. That is the reason why I prefer to avoid wiggling, choosing one particular clock hour and enter into clear cornea. Because if I'm wrong at that point, maybe I am too deep, I will have early entry into the intracameral space. If I'm also wrong at that point, I'm too superficial, I will find myself already buttonholing. So by the time I do 1 to 2 clock hours, widening or tunneling, I will pick it up and check. Am I safe enough? If I'm safe enough, then I'll continue with my tunneling. Wet labs with kitchen food items. People have said with tomato, people have said with the paper of the IOL covering, people have said so many things, but then I think it's my own is more of a mental picture. I need to see an eye. I think that's my problem. If you can do it tomatoes, yes, you can. But if I don't see an eye, I don't feel like I'm doing something. Mine is just personal, please. Whatever anybody has done there, if you check wet labs or home wet labs, Google it on the internet, you'll see a lot of things people have used. Mine probably is just because I want to be seeing some eye, because when I do my accessory, I mean my side pot, I want to put trap and blue. If it is tomato, I will not do that. That's exactly what I'm talking about. Practice eye, yes, practice eye is expensive. The Indian made practice eyes are cheaper, but the ones that come from UK and Europe, I'm sorry, Europe and the US, they are more expensive. But the animal eye, even if before purchasing it to your house, it has spoiled, you can call the abattoir again, they'll send you another one. Practice eye, you might have to come and start advertising who has somebody now you pay, it takes 3 weeks to arrive. And if anything happens to it, remember you have to pay again and it takes another 3 weeks to arrive. So your career is on hold for 3 weeks. But if you go to abattoir today, by tomorrow you have animal eyes. So whatever is practicable, that is the advice. Using +2 or so on your trial frame, what about residents that are hypermetropic? Please adjust your power to it. If you are not ametropic, adjust your power. The whole essence is this: magnification should be there. So you cannot put your surgical career on hold because there's no operating microscope. So if there's adequate magnification and illumination, you can practice anything you want to practice. That is the principles of 10 teachers. That's what we try to incorporate in 10 teachers, that you do not need the bureaucracy of a teaching hospital to push your surgical career forward. You can learn and do anything you want. Wow. Thank you, Mustafa Bature, and I am grateful.
Okay, thank you very much, sir.
Yeah.
And we also have a suggestion on use of apples that we can use it for tunneling. Thank you so much, ma, for that contribution. Okay, so I think that's all for now from the chat box. So we can continue with this tomorrow by God's grace. Sir, tomorrow is fine?
Yes,
8
tomorrow.
p.m. Let's
It's a week-long discussion. So by 8 p.m. tomorrow, we'll continue. Hopefully, we should talk about usually when I do 10 teachers, we use 2 days for each step of capital surgery. So if popular opinion says we should repeat this, then we can go ahead and repeat it. If not, we'll go to capsulorhexis tomorrow.
All right, sir. Thank you so much, sir.
God bless
Thank you for the wonderful. Okay, so let's call it a night. We'll meet again tomorrow. Please, 5 minutes before 8, let us be here so that we can start by 8 p.m. Thank you, everyone.
Please,
have a good night
know.
rest.
Yeah, thank you. Please, can I make something? Sister, something, please. The pre-test. I don't know if Bacteria has administered it. There's a pre-test.
Yes, sir. It's on the chat. Please, yes. Click on the link and fill the form, please. Google form. It's very important.
Okay.
Let's all do that tonight. Thank you, everyone.
Let me type God bless you and thank you. Everybody said thank you. Let me thank you, everybody. Thank you too. Thank you. Hold on. I'm going to typographical error. Thank you all. And capital letter and accomplice. God bless you. All right. Good night.
Have a wonderful week ahead.
Yes,